Next patient is a 23-year-old male with the history of present illness is increase in RV volumes on cardiac MRI. The past medical history shows that the patient is a case of tetralogy of Fallot with right modified BT shunt at 4 months of age, and then followed by intracardiac repair with transannular patch at 2 years of age. The chest X-ray shows situs solitis levocardia with CTR of 55% and adequate pulmonary blood flow. The ECG is normal sinus rhythm with QRS axis of 0, complete right bundle branch block, left anterior fascicular block, and a QRS duration of 160 milliseconds. The transthoracic and transesophageal echo showed a VSG patch intact with severe pulmonary regurgitation, dilated RV, and normal biventricular systolic function. The cardiac MRI values were suggestive of severe PR with a regurgitant fraction of 54%, RV end diastolic indexed volume being 158 ml per meter square, RV end systolic volume index of 83 ml per meter square, and RV EF of 46% against LV EF of 64%. This is the CT axial image showing the various measurements done at the RVOT level, with proximal RVOT measuring 22 mm and main pulmonary artery of 30 mm. And the same with the main pulmonary artery with around 24 to 20 into 28 mm. This is the proximal RVOT in sagittal view measuring 23 mm and main pulmonary artery of 33 mm. This is the angiogram which is done in lateral view showing the waist of around 28 mm and proximal RVOT of 29 mm. The cranial view shows the waist of around 26 mm at the and waist of 26 mm and MPA before bifurcation of 27 millimeters. The same with cranial, we got a waist of around 32 millimeters and MPA measuring around 29 millimeters. During balloon interrogation, the waist was measuring 31 millimeters in the lateral view and of around 29 millimeters in cranial view and 34 millimeters in cranial. So RVOT interrogation details are as shown below. Also, the angiogram showed there was a right femoral vein occlusion with collaterals and there was no coronary compression during the balloon interrogation. Thank you.
Hi, Mario. I have here Dr. Gaurav, Gaurav and Venkatesh, who are doing the preliminary work. As pointed out by Dr. Fareen, the right femoral vein was occluded during the previous surgery. And so we had to go through the left femoral vein, and for the control PA angiogram, we have the right jugular venous axis. Can you show the angio now? I'll just show a couple of pictures. So this is the left pulmonary artery. We have a 24 French long Cook sheath in the right ventricular outflow tract. The hemodynamics was RA pressure of 11 millimeters of mercury, and the pulmonary artery pressures were very ventricularized. It was like around 25/5. There was no difference between the right ventricle and the pulmonary artery in the pressures. So the balloon waist on the RAO was 31 and the LAO was 34. So the only option that we had was 36 venous P valve, the same valve like what we used in the previous patient. Shaq and Mario, any thoughts about the indications as well as the choice of the valve?
Well, I think the indications is quite clear. To some extent, this case is similar to the previous one, with a slight reduction of the origin of the left PA, severe regurgitation. So the size of the valve, I think, yes, it's okay. I think everybody agrees with that. Chuck, do you agree with that?
Yeah, I think 36 seems a reasonable diameter, considering all the various measurements you've made. The length is the
contrast
key question, I think, and whether you use a 25 or...
Shaq, the length of the right ventricular outflow tract in this patient was 35 millimeter. So we asked the venous whether they can make a 35, but then they mentioned to us that they have only 30, and so we are taking a 30. It's a long
Yeah.
RVOT.
Yeah. My other question was, is this current live fluoro? Or not live, but
No,
it's still picture we've got.
no, I can do live fluoro.
Yeah, no. The question was whether you've got the wire you have in the left pulmonary artery. Because I was thinking here, the anatomy is such and the angulation such that it may be and the right pulmonary artery looks bigger, and it may be
Show the
worth
P
thinking
angiogram.
about that. But
Actually, Shaq, in this patient, compared to the previous person, P angiogram, the CT scan did not show a significant difference. No, I want the P angiogram, the LO angio. That's the one. There was not much of difference between the left and the right, unlike the previous patient. So Gaurav got already the valve inside. So now we are going through the 24 French.
Don't change anything now on my.
Siva, you prefer the left PA. We got it.
What is your preference, Mario, for venous P valve?
Well, when I started to use the venous valve, I tell you.
Okay, fine. Okay. Can I have one angiogram, 10 ml at 15 rate? Come this way. Ready? Okay. So now I will get it a little bit more deeper, and I will start opening the valve. Just hold it here. I have with me Jack Lips from Netherlands, who is the venous technical expert, and he has come to help us with the loading of the valve.
Excuse me, Shiva. Will you keep the pigtail deep in the left PA when deploying the valve?
Yeah. I'll pull it little later, Mario. Keep it inside. Shaq, what do you do? Like, would you be happy to keep the pigtail in the LPA in the early stage of deployment? Shaq is not there?
Yes, he's taking the microphone and he'll tell you whether to withdraw the pigtail or leave it there.
I would pull it back because I don't trust myself. I think if you trap the pig distal part in the flare, then you've got a little bit of fiddling around.
Can you give one more angiogram? 10 ml at 15 rate. Okay. I will do that, Shaq. It's a little tighter. This screw is much more tighter. Now, slightly pull out, Venkatesh, the pigtail, marginally. It may flip because it is the jugular axis, or else leave it there. At present, leave it there. If it completely comes out, then I will be finding it difficult to re-enter. Okay. Now, can you make another angiogram? Okay. So now I'm going to pull back. Okay. Show me one more angiogram.
Shiva.
Yep, Shaq.
Just when you've done the angiogram, just take your time, relax, and review.
Okay.
Before the next step. Otherwise, you might rush it.
Yeah, I understand. Venkatesh, can you slightly come down on the pigtail just below the distal flare? Very slowly pull back. It might jump.
now it's stuck.
Enough. Just push it, give the loop again. Fine. Now make one angiogram.
Sure, go ahead. There is a question for you, Steven.
Yeah.
Hold on a second.
Hi, it's Vivian Demas, one of the panelists from Dallas, Texas. So not having used the venous P valve and having more experience with Altera and Harmony, these look like very deep LPA deployments. Can you talk through the deployment of the venous P valve in terms of why the deep distal LPA deployment and the pullback rather than a little bit more proximal, and is there advantage to one or the other approach?
This venous P valve is a self-expanding valve which in the constrained portion is very elongated, whereas when it opens out it shortens significantly. So it is better to go in because if you start deploying it very proximally. Okay, now get ready for angiogram. You see that now part of my open flare is just coming out. So come to RAO position. RAO cranial.
I guess my concern, at least with the self-expanding valves that we use, would be that it would jump and it might actually pull back with too much tension, and how unpredictable that could be. But not having used this valve, that's something that we're always
Go cranial, go more cranial.
That's an important point, Vivian, and that's why one of the reasons I was suggesting RPA, because it's a little less, if you look at the angle between the axis of the valve.
Steve doesn't obey you, Chuck, never.
Come this side. Now, Gaurav, you have to start clockwise rotating.
One more question.
Go ahead.
So in terms of retrievability, is there, when can this be retrieved? Can it be retrieved? And how much can you deploy before it can be retrieved?
Just a second.
Let him do this.
Just a second. Okay, stop there. Now, can you make an angiogram? Shaq, let us see this picture. 50% of my flare has fallen into the right pulmonary artery. I have a small amount of the right pulmonary artery being covered, only the caudal portion. And my annulus is on line with the proximal end of the valve. Do you agree, Shaq?
Yeah, I would now, because you've adjusted it a bit, I would do a lateral or near lateral as well.
Okay, lateral.
This is something that Shiva never do.
Mario, the difference between many of the labs in the West and the labs in India is that we have monoplane. So, and so that is one of the reasons why we less often use lateral. It means a lot of movement.
I think sometimes it can be quite difficult to appreciate the offset, or let's say the offset origin of the branches, and therefore I think it's of course necessary to bridge that one too.
Okay. Now, drop the table. Pull the table towards you. Ready for an angiogram? How much is it? I want 15 ml at 15 rate. Ready? Check here, the proximal end of the valve is at the level of the annulus now. Freeze it.
And you have good flow in both branches actually. In any projection you use.
Come to.
Are you going to pull a bit more the device before deploying completely?
I'm going to pull back. Before that, I would like to go back to. RAO projection.
I would also pull the pigtail back to.
I will do that,
just
sir.
below the middle segment.
Yeah, RAO cranial. Venkatesh, slightly pull out from there. Show the. Just minimally come. Come little bit in. Your hand is getting exposed. Little bit more. Since it's a jugular, it is and it's a 6 French rigid pigtail. I am telling Venkatesh to do it very slowly. Okay, sister, get a wire here.
Just get a Terumo wire and pull it back.
Terumo wire.
Nevertheless, you can do angiogram in the right ventricle as well, and not in the main PA with the pigtail. There is no need to have a pigtail in the main PA, right?
Yeah, I haven't, in my head, I haven't got clear view of where the valve or native valve is in relation to the proximal markers. So, I thought it was a bit lower and so it could come back. But we need to define that.
Show the previous angiogram. Show the previous angio once again. Shak, you see that hold up of contrast is the level of the valve.
Okay, got it. Yeah.
And show the previous picture. Now can you see the hold up of the contrast?
Yeah.
So what I will do is, I agree with Mario. I will probably little bit pull back. This is RAO. Show the previous LAO. Shak, I feel if we release it, it will turn and it will get oriented. What do you say?
Well, I wish the valve was so obedient.
Come to LAO.
Well, the proximal markers are exactly at the annulus level.
Yeah. Okay.
So
Come here,
obviously this is no good, but in retrospect, if anything, the 25 length would have been better.
Yeah, I just wanted to tell that, or mention that too. I think the actual main pulmonary artery is quite short. If you look at the outflow tract altogether, it's elongated, but the portion itself of the main pulmonary artery is quite.
So just before you go any further, Shiva.
Yep.
Well, he's deploying the valve track.
Yeah, okay, carry on.
No, you tell me, Shak. I'm listening.
No,
Get one more angiogram.
I was going to say, just rather than push the system and see if that changes its orientation a bit. But
Okay. Come
now
to.
you can't really because.
No, it is possible, Shak. Actually, I'm going to come to RAO now. I just wanted, in this picture, I am very clearly seeing that my distal flare is across the RPA origin. Freeze it.
Yeah.
So I have protected the flows in the right pulmonary artery. Now I have to ensure.
Do the lateral again.
I have to ensure that the RVOT I don't. Okay, now I'm going to give a forward push, while my colleague Gaurav is going to release it further.
Yeah.
And the
So
release, it's going to. Okay.
I would do an angio before that final release in that projection.
Okay. Now
It looked a bit better.
get angio.
Yeah. I'm happier now with the position because I think it's orientating itself. So if you keep a little push as you release.
The patient is fighting the ventilator, little bit sedation. Okay. Now keep slowly deploying. Yep. Okay.
And store that because you'll see
Store
right
it.
at the end the distal flare moves a little more proximal.
Yeah, we have stored it. Now this is coming now.
Yeah. So just watch where your distal flare was originally
Yeah.
before you released it and then how it changes a bit.
Get ready for another 20 ml angiogram. Ready? Ready?
Yeah. So there is one more thing, Shiva.
Yeah, the eyes of the venous valve, I have to ensure that they are fine.
Correct. So the proximal one of them may not be fully released. So
Yeah, I'm going to check it. Now, in this view, let me identify whether there is an eye. I'm not able to see. Go to LAO cranial.
I call it ear, but you call it eye.
Ah, okay, ear. I will also use the same.
But if you rotate the handle, then it might release itself.
Yeah, I'll do that.
You see it's held up.
Okay, now let me see whether I have completely, oh, it is still not fully open. Okay, now only we have opened it fully.
Yeah.
And now I'm rotating. It looks like
But
I
store that, because again, that's
store
educational.
and store it and play it again. You see, now we are actually releasing. You see that now it is still not released. I am now slowly pulling the gold ring back. There is a change in the configuration.
Yeah.
And now at this position, once again, let me see whether I am seeing the ears. Is that right, Shag?
Yeah, one's just covered, but if you look at the other plane as well now.
Okay, come to AP cranial. AP cranial, AP cranial. I have one.
See
I have one
Yeah,
at around 3 o'clock.
lateral, yeah, and one just next to the
Exactly.
attachment point.
Exactly. I agree. So now, let me come to RAO. I will try to take the carrot out.
Shiva, can you point out your eye and Shaq's ears to the audience, because it's not very clear.
Okay. Now I will take a cine and point it out, Joseph. Okay. Now make it double zoom. Zoom. Next zoom. You can't magnify. Now push it up. So Joseph, you see that there is one at.
If you freeze it.
Freeze it. Freeze it. Freeze.
You have to point.
Okay. Now you.
Stop frame and you point with the marker.
Okay. Now take an arrow.
Well, Shark is trying to point with his hand, but it's not tall enough.
Okay. Okay. Now come down. Come down. Down. Come down. Take your arrow down. Down. Come to the right a little bit. Right further. Stop. Little left. You see, that is 1 ear. And now go across.
Is this Shark's hand?
Okay, this is 1 ear and second, just go up. That is the second ear. Now get back to normal mag.
That very nicely.
Normal mag. I'm going to.
Can everybody see then? Yes, they say yes.
I am trying to.
Careful now, you see the folding.
Yeah, I saw that, but how can I help it, Shaq?
So on the lateral or LAO.
I'm rotating, Shaq.
Go lateral or LAO.
Lateral.
Steady.
Lateral, full lateral. Shaq,
Okay,
I
actually
have.
it's now through, but it's come through anyway now. So, but what you could do whilst you're there is, never mind.
Shaq, it has come.
I tend to pull the wire, and that drops it down from the distal flare.
Yeah.
You mean release the tension of the system? That's enough to get it free.
Yeah.
And also pigtail.
Okay. Now get ready on angiogram. 20 ml at 15 rate. Shaq, the position looks okay for me here.
If you look at the lateral and where the RPA is, where it's going into the picture,
Yeah.
It's the distal flare is absolutely perfect position.
Tell that again, Shaq. The distal flare is?
So
Come to eleocranial.
if you look at freeze that picture.
AP.
We haven't got a pointer here, have we?
But I can't see your pointer.
No, right. So if you freeze the picture.
Freeze the picture. Freeze the picture when the angio is seen. Stop. Yep.
You see that oval shape?
Yeah, right
contrast,
pulmonary, pulmonary artery.
So that's the right pulmonary artery going into the picture.
Yep.
And that, if you then match that against the distal flare.
Yep.
So the distal flare is just partly covering it, but it's much more proximal than it was originally.
Yeah. So
I usually use that RPA as a good guide.
Come to AP. Okay. So now what I'm going to do is show the valve. Show the valve below. Come to the IVC. Okay. Now I'm going to resheath. Show me the nose cone, carrot. Oh, I have come too much inside. Okay.
You've been too quick.
Okay. Now I have got the gold marker inside. So now I am taking it out of the. I already told that the right femoral vein is occluded, and so we are using the lift. Okay. Now go back to the heart. Show the valve. Do the fluoro for me, Gaurav. Keep continuing.
So just on that distal flare and the carrot, it's counterintuitive, but if you pull the wire, it drops it down away from the distal flare, and then the carrot comes out easily.
Yeah.
Yeah, I think this is a very important point of the procedure, because when you deploy the entire valve and in a good position, you can think and say yourself, well, that's gold.
Venkatesh, get that RV to pressure.
Pull everything back to right ventricle if you're not careful.
Get it here.
The same peculiar particular that all the self-expanding valves actually, for the booster valve as well as I'm experienced with, that's the same problem. So you have to be sure that everything is free before getting back into the right ventricle. Yes.
Now that the valve is deployed, can we talk about recapture? And if you can, touch on that.
Yeah, so Shiva, you continue and I'll cover this bit because I don't want you to trap the pigtail in the distal flare and the proximal flare because you've got both.
Yeah. I have got the jugular pigtail below the valve and the femoral pigtail above the valve.
Yeah. So you're snaring both the flare, distal and the proximal flare nicely. So retrievability is if you use
put it on the same scale
or something similar, then up to about half the valve exposed, you can recapture it. You can't recapture it with the delivery system covering sheath. Once you expose the distal flare and come to that,
make the hemodynamics big.
Then you can't. So that's why
change the color to this one to white. The RV to white color. The valve closure artifact is seen. You can see that the pulmonary artery, during the crossover between the RV to PA, there is a sharp flick. Increase the speed. Take the mean out of the RV. Only PA should have mean, RV should not have mean. Okay, now you see that there is a sharp valve closure artifact, and that is an indicator that the valve is touching the pigtail and it is causing that artifact, a sharp deflection. Can you see that now?
Yep. Yes, we can see
and
that
there is a diastolic gradient. So now I will make a angiogram here in the pulmonary artery. To start with, in lateral view, so that I please Dr. Shak Qureshi. Lateral view first. Shak, are you happy?
Yes, yes.
Thank you.
As long as the pigtail releases the distal flare.
I think it is not trapped.
No, I'm joking.
Okay. Okay.
But for the angio, you've got to pull the pigtail back a little bit.
Okay.
Because otherwise you'll only pacify the pulmonary artery. Yeah,
Okay.
left pulmonary. Yeah, that's it.
Yeah. Ready for 20 ml at 15 rate. 20 at 15. Ready? Okay. The valve is competent.
Excellent.
Show this picture. Elevocranial.
Siva, you still have a wire into the left coronary. Are you going to do a coronary angiogram
Yes. I will do that in an appropriate projection. I like it in the profile projection. I will do that now. I'll show you what I do. Can you give another? Now give 25 ml. I want more contrast in the PA. Ready? Shoot. The proximal markers are matching the annulus. Now come to AP caudal. Make an en face view of the valve. No, that's enough. Dye is enough. En face. Correct. I want that picture.
Why you're doing this view? Just to make sure to have a round shape of the valve, or what?
The left.
To avoid, I would say, an oval shape of the valve. What's the reason to do this projection?
You see that left main coronary artery or the proximal LAD may be compressed by the venous valve, and hence we want to see the left main coronary and the proximal LAD just below the valve. And if in this particular projection, if it is not compressed, then it is not compressed. Can you see that?
Yes, sure.
Okay, so now let me find out whether the jugular pigtail is safe. Give me the wire, thermo wire. I come to AP view. How far is the next lap? Just check. Okay, so I have got the jugular pigtail out. Venkatesh, take it out. Let me take out this femoral pigtail also. Okay, and I am taking out the coronary wire and the coronary catheter.
Absolutely spot on, perfect, isn't it?
Shaka, we have a very interesting, very fascinating ventricular septal defect in the other lab, or do you want me to show the figure of 8 stitch here? I think that will be more interesting.
Well, let me ask the audience. Would you like to see the
Come here, close.
Two
silk.
Figure of 8
Come closer.
Yes or not? Are you interested?
Come closer.
Well, apparently nobody's interested.
Okay, then.
But you will show it. You will show us anyway. Just in the.
Okay, I'll do that.
In the next 30 seconds. So go ahead.
Okay. So now.
Go to the other lab, Shiva.
Okay, Gaurav, do this.